for recognition of the patency of the ulnar artery. And if radial artery, we will occlude by finger, and we will release the ulnar artery. So if there is good perfusion to the hand, it means we can utilize the radial artery for procedure. To know abnormality of ABG, of course, we have to know the normal values of ABG, and it's represented in our slides with the pH 7.35 to 45, PCO2 35 to 45 millimeter mercury, and saturation 95 to 100%, bicarbonate 22 to 26. In some sources you can find up to 28 millimole, and with base deficit or excess ±2. We can get other valuable information from the ABG as hemoglobin level, sodium, potassium, lactic acid level, carbon monoxide, and methemoglobin levels. So how to regulate the pH, our body pH is regulated by respiratory and renal system, by excretion of the carbon dioxide, elimination of the bicarbonate, and production of the bicarbonate. So lung and kidney stands for each other for regulation of pH. This slide represents the normal value as well as the extremes of the pH. As you can see, at extreme of 6.8 or 7.8, rapid deaths occur. One of the famous equations in ABG is a Henderson-Hasselbalch equation. Of course, this long equation, which you can see on your screen, we cannot utilize in our daily practice. So, following equation, which is on the top of this slide, we can use to know the consistency of the ABG. So, the relation between hydrogen ion, PaCO2, and bicarbonate in the body, it's a Henderson-Hasselbalch equation. By this equation, we can check the eligibility of our ABG sampling. As you can see on these slides, there is relation between hydrogen ion content and blood pH. As you can see, it's vice versa, going in opposite directions. Coming to slide how to read ABG. So there are 6 important steps. Step number 1 is this acidemia or alkalemia. Step number 2 is the primary disturbance, respiratory or metabolic. Is the respiratory problem acute or chronic? For metabolic disorders, what is the anion gap? Question number 5, are there any other process in anion gap acidemia? And last question, which we should find the answer, is the respiratory compensation adequate? Acidemia and alkalemia, it's actually the pH in first case less than 7.35, and in case of alkalemia more than 7.45. Acidemia and alkalemia, it's also classified to metabolic and respiratory, depends from bicarbonate or PaCO2 involved. So this is a nice algorithm regarding the respiratory disorders. So respiratory disorders, they are classified to oxygenation and ventilation disorders. Oxygenation disorders includes hyperoxemia and hypoxemia. Hyperoxemia is almost always iatrogenic, and it's very easy to overcome with controlling of oxygen supplementation. And hypoxemia classified to hypoxemia with low PaO2 and normal PaO2. Main causes of hypoxemia with low partial pressure of oxygen in the blood are diffusion problem, vacuum mismatch, hypoventilation, low oxygen in ambient air, and right to left shunting. We can see the hypoxemia with normal PaO2. So causes for these pathologies are anemia, carbon monoxide, methiminoglobin, cyanide poisoning, as well as hypoperfusion state. Coming to ventilation disorders. Ventilation disorders classified to acidemia and alkalemia. It depends from the level of the PaCO2. In case of acidemia, it's classified to acute or chronic. So simply the causes for acute acidemia, we can tell about traumatic brain injury, anesthesia side effect, Guillain-Barré syndrome, myasthenia and gravis. And for chronic, very famous pathology for chronic ventilation, for chronic respiratory acidemia, it's a COPD. Alkalemia, it's a presence of high pH with low CO2 and causes for those hyperventilation, pregnancy itself, respiratory stimulants as caffeine, for example, doxapram, and liver failure. Dr. Ahmed, please, if you can make pull for this question. So we will discuss the case number 1. A patient presented with 1-day history of productive cough, fever, and dyspnea. His ABG with pH 7.55, PCO2 of 30, PaO2 63 millimeter mercury, and bicarbonate 22 millimole. So please comment on this ABG. Dr. Ahmed, can we make the poll, please? You can answer in chat as well. Actually, I cannot see any pool and I cannot see any chart for this question. So answer here the respiratory alkalemia and hypoxemia. Now we will move for discussion of acid-base disturbances. They are classified to primary and mixed disorders. Primary acid-base disturbances, of course, includes the respiratory and alkalemia, and I think we'll, okay. Yes, 100% voted well. Thank you, Dr. Ahmed. Yes, now I can see it on the screen. Yeah. Okay, thank you very much. I think we can stop voting and we can go for next slide. Fine, thank you very much to everyone. So, as I mentioned previously, acid-base disturbances classified to primary and mixed. Primary includes respiratory acidemia with alkalemia or metabolic acidemia with alkalemia. Mixed disorders. This combination, there are possible combination of all of these apart from respiratory acidemia and respiratory alkalemia. In one ABG, you cannot see at one time presence of these two disturbances. Okay, this sketch there representing the presentation of the patient with metabolic acidosis and metabolic alkalosis. There is no specific or some specific presentation. For example, for metabolic acidosis, mild respiration, you can see it in DKA cases, right? And this metabolic alkalosis patient again presents with confusion, dysrhythmias, and compensatory hyperventilation, etc. Now I will move to the important algorithm regarding the alkalemia and acidemia. So red boxes here represent the acidemic state and blue boxes alkalemic. Coming to acidemia state, there is metabolic and respiratory acidemia, and let us follow the metabolic acidemia. if you will find in the ABG metabolic acidemia, you have to calculate anion gap of the patient. What is the anion gap? It's you have to subtract the serum sodium level, subtract from serum sodium level sum of the chloride and bicarbonate. Okay, so it will come 12 plus minus 4 is the normal reading. If patients have the metabolic acidemia, you have to calculate the anion gap. Next step, if anion gap normal or high. If high anion gap, we have to move to next step of recognition of mixed disorder. So what you have to do, you have to make the ratio between gap of the anion gap with the gap of the bicarbonate. So if this ratio between 1 and 2, patient have only high anion gap metabolic acidemia. If this ratio less than 1, patient have concurrent normal anion gap metabolic acidemia. If this ratio more than 2, patient having combination of the high anion gap metabolic acidemia and metabolic alkalosis. In some situations, we have to check the osmolar gap. Osmolar gap, normally it's less than 10. And with elevation of osmolar gap, we can see in, for example, in toxic alcohol poisoning. So you have to check the osmolar gap, as well as we have to correct the anion gap to albumin level, because as we know, albumin is a weak acid, and in case of hypoalbuminemia, we have to correct the anion gap of the patient by you have to increase to every 1 gram per deciliter loss of albumin by 2.5 millimole of increase in anion gap. Causes for high anion gap metabolic acidosis you can see in the box. You can memorize as mud piles. And in case of normal or non-anion gap metabolic acidosis, we have to calculate the urine anion gap. So if urine anion gap is positive, cause for normal anion gap is renal. And if urine anion gap is negative, cause of normal anion gap is non-renal. Again, how to memorize the causes for normal anion gap metabolic acidosis? Just you can memorize the mnemonic fused cars and all the possible causes. It's mentioned in the red box. Coming to alkalemia. Alkalemia, it's a presence of pH more than 7.45 with the bicarbonate more than 26 or PaCO2 less than 35. In this case, it will be respiratory alkalemia. Coming to metabolic alkalemia, if patient have metabolic alkalemia, we have to check the urine chloride. If urine chloride less than 10 millimole, so this chloride responsive metabolic alkalemia. Causes for possible causes can be vomiting, continuous suction, diarrhea. If the urine chloride more than 10 millimole, so there is chloride resistant metabolic alkalemia. Causes for this: mineral corticoid excess, ACTH excess. And last box is causes for respiratory alkalemia, includes hyperventilation, pregnancy, liver failure, respiratory stimulant, as I mentioned previously. All these slides, which I will skip actually because I discussed already during the discussion of the algorithm. And as you can see, for high anion gap metabolic acidosis, there are many mnemonics as a slumped, mud piles, etc. Okay, these all slides actually I discussed during discussion of the algorithm. Now we'll move to second case, study number 2. So otherwise healthy 50-year-old male sustains acute upper airway obstruction during the induction anesthesia, then he vomits, and ET tube was placed, and ABG were as follows: pH 7.1, PaCO2 70, bicarb 15, and PaO2 55. Please comment on this ABG, and Dr. Ahmed, if there is pool, so can you put it early, please? Is there pull? You can answer in the chat also. Yes, most of delegates answered 3 yes. The correct answer is 3. So we will move to next. Okay. Case number 3, 56-year-old man with COPD and resting PaCO2 of 70 mm mercury sustains an acute myocardial infarction. His blood pressure 85/58 mm mercury, and he is diaphoretic with cool and clammy skin. His ABG with pH 7.1, PaCO2 70, PaO2 73, and bicarb of 21. So please, if you can give your answers. Okay. So there is mixed answers, 2 and 3, 2 and 3. The answer for this question is, as you can see, patient has pH 7.1, so this acidemia, PaCO2 70. Yes, this acidemia, but as I mentioned previously, acidemia is chronic, as patient has history of COPD. PaO2 of 73 and bicarb is 21. So patient has chronic respiratory and acute metabolic acidemia. We will move to the next. Okay. So these slides are showing the rules which you have to memorize. It's the rules of compensation for mixed disorders. So in case of metabolic acidemia, also already there is a process of compensation by CO2 elimination. So PaCO2 will decrease by 1 to 1.5 times in bicarbonate decrease, or last two digits of pH should be equal of PaCO2. So it means the processes are compensating each other. In case of metabolic alkalemia, PaCO2 increase by 0.25 to 1 times will increase in bicarbonate. And these slides represent another rules we have to memorize. For bedside interpretation of ABG, there is respiratory acidemia and respiratory alkalemia, and how compensations occurs between the respiratory and renal system. So in respiratory acidemia, acute PaCO2 rise by 10 mm mercury will lead to increase in bicarbonate by 1 millimole per liter, it's in the acute case, and by 4 millimole per liter in chronic cases. For respiratory alkalemia, there will be also compensation for acute respiratory alkalemia. For each 10 millimeter mercury decrease in PaCO2, there will be 1 to 3 millimole decrease in bicarbonate. And in chronic status, for each 10 millimeter mercury decrease in PaCO2, there will be 2 to 5 millimole compensation or decrease in bicarbonate. This another maybe funny method of recognition or bedside interpretation of ABG. It's called the tic-tac-toe method. It's very easy. As you know, it's one of the indoor game for kids. So you can make the boxes with acidic, normal, and basic boxes. And let us make the trial of this method. So we have the ABG with pH 7.25, PaCO2 of 32, and bicarbonate of 18. Knowing the normal value, as I mentioned previously, we can place the pH to acidic box, bicarbonate also to acidic box, and the PaCO2 to basic box. So we have metabolic acidosis here. It's very easy to interpret. Now we will discuss the compensatory, how to interpret the compensation at the bedside. So we are moving to next slide. So how to determine the compensation. So if in ABG pH is normal, PaCO2 and bicarbonate are both abnormal, this is a compensated state. If pH is abnormal and PaCO2 and bicarbonate are both abnormal, it's a partially compensated state. If pH is abnormal, PaCO2 or bicarbonate is abnormal, it's uncompensated state. So let us try this ABG with pH 7.43, PaCO2 of 30, and bicarbonate of 21. So pH is normal, PaCO2 is basic, we are placing at the under basic box, and bicarbonate we are placing under acidic box. So we have normal pH and abnormal PaCO2 and abnormal bicarbonate. So it's a compensated disorder, as you can see here, because normal pH and abnormal both of the other readings. Those are multiple formulas for ABG interpretation, and it's very difficult to memorize them, and actually no need to memorize them apart from the first formula. It's called the Winter formula. It's a compensation between the compensation in metabolic acidosis. So compensation between the PaCO2 and bicarbonate. This formula we have to memorize from all those formulas, and we can utilize this formula in our daily ABG interpretation. And this is the last slide, how to read the ABG, 6 simple steps. Number 1, is this acidemia or alkalemia? Is the primary disturbance respiratory or metabolic? Is the respiratory problem acute or chronic? For metabolic disorder, calculate the anion gap. And are there any other processes in anion gap acidemia? And question number 6, is the respiratory compensation adequate? So thank you very much. And if you have any questions, don't hesitate to ask. Okay, can you tell me the normal range of bicarb and PaCO2? So normal range of bicarb, 22 to 26, and it's the national range, and normal PaCO2, 35 to 45. Not, yes, exactly, 35 to 45. If you will memorize the normal reading, it will be easy to read ABG. So most important, memorize the normal reading of ABG. Any other question, please? Yes, urine anion gap. Urine anion gap we are using for normal anion gap metabolic acidosis, and the urine anion gap but you can find by this formula. So we have to send the urine sample to laboratory and ask for urine sodium, urine chloride, and urine potassium. So sodium minus sodium plus potassium minus chloride. This is a urine anion gap which we can use in normal anion gap metabolic acidosis. Any other question? Okay. I think Dr. Ahmed, I completed my presentation, and we can move to another presentation. Thank you very much.
Good afternoon. This is Dr. Shahzad. Can everybody listen me? Ahmed, is my voice is clear? So I will hand over to the lecture next CPR dynamics in COVID-19. Dr. Saima Akhtar is with us. She is the ICU consultant and head of CPR dynamics in King Saud Medical City. So over to Dr. Saima Akhtar.
Assalamu alaikum. Um, Thank you, Dr. Shahzad, for the introduction. I hope all of you are enjoying the training of ICU and the knowledge which is being distributed till now. As you have come to know, I will be talking about CPR dynamics in COVID 19. Basically, I will like to go quickly through the guidelines which are endorsed by the American Heart Association for the advanced cardiac life support. And by the end of my lecture, inshallah, you will be able to understand the importance of team dynamics and will be able to explain the role of team leader as well as the team members. And we'll go through the guidelines for the CPR in the COVID 19 patients, both the confirmed or suspected cases, and what type of precautions we have to apply while dealing with these patients. As all of my colleagues are ACLS provider, so this slide is not new for all of you. Basically, I will like to go through the chain of survival, and this is the most important slide. As you all know, the chain of survival refers to internationally recognized standard of early interventions, which gives the victim of sudden cardiac arrest the best chances of survival if implemented timely and actively. So basically, these events they should occur rapidly and integrated manner. These include for early recognition of cardiac arrest, along with the activation of emergency response, immediate high quality CPR, early defibrillation, and advanced life support, followed by the post resuscitation care. While we are discussing about high quality CPR, I would like to just go quickly through the 5 important components of high quality CPR as endorsed by the American Heart Association. As we know, we are talking about push hard and push fast. So by fast, we mean at a rate of 100 to 120 compressions per minute and at a depth of at least 5 centimeter, which is approximately more than one third of the anterior posterior diameter of the chest, allowing for the full chest recoil in between the compressions with minimal interruptions and adequate ventilations. And for sure, we all know for every 2 minutes, we have to check for the pulse and we have to rotate the compressor every 2 minutes or sooner if they get fatigue. The teamwork always makes the dream work. And a successful team is a group of many hands and one mind. And basically, the successful team is not only having medical expertise or the resuscitation skills, but they also demonstrate effective communication and effective team dynamics. Whenever there will be any cardiac arrest while you are rotating with us, you will be supposed to be the first responder and the team leader till another senior will come and take over the situation. So here it is very important to understand the role of a good team leader. For sure, you know that you have, as a team leader, you have to organize a group to monitor the individual performance of the team member. And good team leader always is involved in the training and coaching, as well as he's a backup for his team members in case if they fail to do some maneuver, and is a model of excellent behavior. And he has situational awareness, means he is paying attention to whatever is going on around and is not fixed to only one problem. And while we are the member of the team, we must respect the authority of the team leader and should be ready to carry out the instructions from him. As we all know, the poor leadership will induce frustration and anxiety and will have the negative impact on the team as well as the future performance of the team. As the team leader is having the comprehensive patient care, his complete focus on it. But while we are the team members, we should focus on our individual task. Means we should be very clear about the role assignment. We should be prepared to fulfill our roles and responsibilities, and we should be very well practiced in the resuscitation skill. It means knowing limitations. Like if we know uh, the boundaries of our expertise, means we are able to ask for help early. to ask for help early before the resuscitation efforts they go worse. This is known as knowing for the limitations. And for sure, we are knowledgeable about the algorithms and committed for success. While we are talking about the team dynamics, these are basically the forces which are operating within the team. And to have the effective team dynamics, there are certain characteristics which are supposed to be the basics of a good team dynamic, which include closed loop communication, clear messages, clear roles and responsibilities, knowing limitations and knowledge sharing, constructive intervention, re-evaluation and summarizing, as well as mutual respect. And we all know that communication is a very important component, particularly in the time of high stress. And once we are talking about communication, we mean effective communication. And once we are speaking about effective communication, we are talking about closed loop communication. And it is very obvious, like closed loop communication will reduce the errors, it will remove the ambiguity, it will allow for the questions if the instructions were not heard clearly or if it was not delivered properly. Like suppose the team leader wants to have a procedure to be done by the member of the team, he will ask for it particularly by naming the member, and the member will confirm by asking it and will perform the procedure and will acknowledge it back to the team leader. Let's take a very simple example. Like if we are having a patient in cardiac arrest, and I want to have a large bore IV cannula to be inserted, so I can ask Shahzad, I want you to insert a large bore IV, and he will confirm from me by asking, you want me to insert a 16 gauge IV, which is appropriate. So he will insert the large bore IV, and he will respond back to me, okay, large bore IV is in. So this is an example of closed loop communication. As well as the clear messages, these are very important. As a team leader, we should deliver the messages in a consolidated way and a controlled tone of voice, in a calm manner, to avoid yelling or shouting or being angry. We all know that unclear communication, it will delay the treatment and it also lead to medication errors. uh, a small example, like I want to give adrenaline, I can ask a member of the team, like, Asma, give adrenaline. It's not a clear message. Instead, we should ask her, Asma, give adrenaline 1 is to 10,000, 1 milligram IV push. And she will reply back, adrenaline 1 milligram IV push given. So, this is a very good example of not only the closed loop communication, but also the clear messages. We cannot overemphasize the importance of clear roles and responsibilities. It is very important because otherwise, all the members of the team may be performing the same task, missing the essential task, and it will lead to freelancing of the team members, and it will lead to ineffective team dynamics. So, it is the responsibility of the team leader to delegate the task early while we are initiating the CPR. So, each member of the team is aware about their clear roles, and it helps us to break down the boundaries between the individual with the varying level of experience. So if we are unsure about their responsibilities, do not assign the task. And it is very clear, if the team leader he wants to endorse some additional responsibilities to any member of the team, he must discuss and communicate with the team member. So this is one of the picture which is showing the ideal number of people, the minimum number which we require for an effective team dynamics during the CPR. So ideal number should be at least 6 members, including the team leader, and there is one responsible for airway breathing, and one is responsible for compression. Another colleague is responsible for compression as well as defibrillation. So they will switch the role, and one is responsible for vascular access as well as for IV medications, and the other one can take the role of documentation. But here there will be a difference, because as we are going to discuss about the CPR dynamics during the arrest of a patient with suspected or confirmed COVID-19, as per the recommendation by the Resuscitation Council UK and American Heart Association, they are endorsing to keep the number of persons as minimum as possible, reducing it up to at least 4, and the rest of the team can be present outside the room, ready, standby. In case if we need help, we can involve them. As I already told you, the important components of team dynamics, I will quickly go through some of these important pillars, like knowing limitation. As I discussed before, if a member of the team is aware that he cannot perform a procedure, should ask for help early. Means early advice before the situation gets out of hand. Like if someone is unable to establish an IV access, we should stop trying again and again and ask for help early. Similarly, if someone is not confident enough to do the endotracheal intubation, can continue to maintain oxygenation by EMBO and mask ventilation till an experienced person will come and take over the situation. Similarly, fixation error is a very important component. It refers to sudden stuck on the skills or the knowledge when working with stress. Like the team leader may become trapped in a specific treatment or diagnostic approach. So, how to solve the fixation error? The answer is simple: sharing the knowledge. So, getting the contributions from everyone in the team can solve the fixation error. Whenever resuscitation efforts are ineffective, go back to the basics and talk as a team. And the team leader should ask for the differential diagnosis to identify the reversible causes, which are the H's and the T's. And as a team leader, we should not ignore other suggestions for the treatment, and should not fail to examine the signs that are relevant to the treatment. If during the resuscitation any action which we notice is inappropriate at the time, or any drug which is advised to be administered is inappropriate, or the dose is not correct, so as a member of the team we can play the role by constructive intervention. It means we'll attempt to stop in a tactful and a professional way when something is being the is not appropriate at the moment. Like we can suggest an alternative drug or a dose in a confident manner. And debriefing is very important. And afterwards, the debriefing, along with the constructive criticism, will help in improving the performance of the team overall and will lead to the learning. Similarly, the reevaluation and summarizing is important. It means the team leader, it can summarize the periodic update to the team and also the patient status along with the assessment finding, and should reevaluate the resuscitation attempt and announce the plan for the next few steps. Similarly, the patient condition, it can change anytime. So we have to remain flexible to changing treatment plans and visiting the initial differential diagnosis. And the mutual respect is the cornerstone of the best teamwork, because the best teams always work in a collegial and supportive manner. And we must abandon ego and overconfidence, and regardless of any additional training or experiences that we possess, we should always speak in a friendly and controlled tone of voice, avoid shouting or displaying the aggression. And we must acknowledge by saying thanks and good job. So this is the
Sorry,
most
Dr. Osama, we cannot see your slides, please. Can you share, please?
Sharing again.
We cannot see your slide. It's not appearing.
Aha, okay.
Yeah, thank you.
Now, is it okay now?
Not yet, doctor.
Is it okay now?
Yes, yes. Now it's visible.
Yeah. So this is a very important slide. I will like all of you to focus on it. It looks very busy. I will try to make it as simple as possible. As we all know, during this pandemic of COVID-19, interim guidelines were released by Resuscitation Council of UK on 26th of March. And also the American Heart Association, they have released their guidelines with modifications in approach as well as the resuscitation of these patients during the cardiac arrest. And as you can see, on the left side of this slide, there are mentioned phases. So this slide, it is basically giving us 3 different phases of resuscitation: phase 1, phase 2, and phase 3. And the phase 1 is the most important because it is involved in the conversations and decisions regarding emergency management as well as the treatment escalation for these patients. Because the more emphasis is from all the schools of thought is on the early decision regarding the treatment escalation, which should be done early, individualized, prioritized, and should be documented and communicated with all the members of the team, because to avoid unnecessary and unprotected CPR. So here comes the importance, because the safety of the healthcare workers have been the prime importance for all of these guidelines. So the phase 1 is on discussing basically about the core status for the patient. And if we feel the patient condition is not appropriate to continue with the aggressive management, the decision about do not attempt CPR, it should be done early, and the patient can proceed with the end of life care. In the phase 1, we don't need appropriate or any specific PPE, but with the phase 2 and phase 3, specific type of PPE are recommended. In the phase 2, at least level 2 PPE, which consists of disposable gloves, disposable apron, and the surgical mask, along with the disposable eye protection. This is the minimum required. And in the phase 3, which is dealing with the aerosol generating procedures like intubation, airway interventions, here we need proper PPE for phase 3. That is including the disposable gloves and gown, as well as a respirator like N95, fit tested, along with the disposable eye protection. So if we see the patient is unresponsive and is not breathing normally, we'll check for the pulse, and we'll call the resuscitation team, and we'll mention about the COVID status for the patient. Again here, why it is important? Because the team which will come to help will be having appropriate PPE for the phase 3 for aerosol generating procedure. As we all know, the chest compression, these are the aerosol generating procedures. So if we are not having appropriate PPE, will not proceed for the chest compression. We'll assess the rhythm for the patient, and if it is a shockable rhythm like VF and pulseless VT, we can shock the patient if we are not in the appropriate PPE. And we can deliver at least 3 shocks till the help will arrive, and can proceed with the further algorithm after donning the PPE for the CPR, followed by minimum interruptions and high quality CPR for these patients. And if a patient is having non-shockable rhythm like PEA and asystole, will not initiate chest compression until we are having the appropriate PPE for aerosol generating procedures. So, and immediately, like if there is once the team is there, we do the CPR, we'll follow all the other algorithms as per the ACLS guidelines. And if there is return of spontaneous circulation, we'll manage the patient with the post-dose care, maintaining the ABCD approach. We'll aim for saturation of 94 to 98%, as well as the normal CO2. We'll do the 12-lead ECG to look for a cause, precipitating cause, and the targeted temperature management will be initiated. And if we have to proceed for other interventions like a bronchoscopy or intubation, we'll go with the level 3 PPE for these patients. And some things which we can add additionally in the care of these COVID-19 patients, like ultrasound imaging, it can be utilized. Mechanical chest compressions, if available, it can be utilized to facilitate the transfer and to continue with the treatment, as well as to decrease the involvement of the healthcare workers during the CPR in order to decrease the risk of contamination of the healthcare workers. Similarly, eCPR, it can be provided for these patients if the facilities are available. So while I will proceed with my other slides, I will still again like to emphasize the importance of treatment escalation and resuscitation decisions for all the inpatients. It must be done early, it must be documented, and it should be prioritized. And whenever we recognize the cardiac arrest, do not put your face near the patient face to listen or feel for breath. So this is the difference. Only feel for the carotid pulse and call for help, and state the risk for COVID-19. We'll attach the defibrillator and will shock if indicated. And here I believe in both the guidelines, there is great emphasis on the shock. As we all know, in the chain of survival, early defibrillation is a very important link, but it is the weakest implemented link. And more than 50 to 70% of the sudden cardiac arrest victims, they survive. if defibrillation is provided to them within the first 5 minutes. And for every minute that passes later on, there is a 10% less chances of survival. So the more emphasis on defibrillation could be because of this reason, because there is a good survival for these patients who have a shockable rhythm. Secondly, it could be because the rhythm assessment as well as defibrillation, it does not require level 3 PPE. So even if you are not in level 3 PPE, you can still administer the shock till your team will arrive to continue with the chest compressions. And in ideal situation, if early restoration of circulation is there, it may not need even the chest compression and ventilations. Whenever after donning the full PPE for aerosol generating procedures, you will proceed for the chest compression, and no compressions or airway procedures should be done without the proper PPE. If patient was not intubated and was on oxygen by face mask, so what we can do, we can leave the face mask on the patient face for oxygen, and we can do the compressions only CPR until the most competent and experienced member of the team is available to intubate the patient. And we'll restrict the number of the staff which are attending during the CPR. And here also would like to emphasize the role of the experienced and the competent person who is intubating the patient. Ideally, they are recommending to use the video laryngoscope to minimize the number of attempts which are taken. And as soon as patient is intubated, should be connected to the ventilator along with a viral filter and with a closed suction. And the closed suction should be tried not to discontinue more frequently. Meanwhile, we'll also go to assess and find the reversible causes of cardiac arrest. Here we are discussing about the S and the T's. I would like to go quickly about, as you all know, the H, they stand for hypovolemia, hypoxemia, hyperhypokalemia, acidosis, and hypothermia. And with these, we mean tension, pneumothorax, and cardiac tamponade, and massive thrombosis. It could be acute MI or massive pulmonary embolism, and toxins. And once we are finished with the CPR, the most important component is to dispose of all the material which was used during this chest compression. Either to dispose of or clean all the equipment which was used. Like if we use the laryngoscope, don't leave it on the pillow of the patient. It should be placed on a separate tray on the side of the table and can be disposed of properly. Similarly, the yanker which was used for suction, it should not be tucked below the pillow. We can put it on in some disposable glove. Later on can be disposed according to the infection control recommendations. And don't forget to remove your PPE safely to avoid self-contamination. And all the disposable dispose of will go in a clinical wastage bag and will be disposed of properly. And the importance of hand hygiene cannot be overemphasized. And post-resuscitation debriefing is always very important. It helps to reduce the errors and to help improve the performance for the future team dynamics. Moving to the last slide of my lecture, this I will say as a take-home message, the importance of decision making. The conversations and the treatment escalation planning, it must be prioritized, must be individualized, and it must be documented as well as communicated well within the team in order to avoid unprotected CPR. Early identification of suspected and confirmed COVID-19 patients who are at the risk of acute deterioration or sudden cardiac arrest. It is important because if the patient is active code, you will bring the patient to the appropriate area with appropriate expertise early, and where all the proper protective equipments are available. Here again, the safety of the healthcare workers is a priority. So with this, I would like to end my lecture. And if you have any questions, I will be happy to answer. And
thank you, Dr. Saima, for important and comprehensive lecture. Please, if someone have questions, you can write in the chat or raise your hand. Any questions? Yeah.
so if I will be still online. If somebody has the questions, can send to me. I will be available in chat. And I would like to wish happy Ramadan for all of you. And
Dr.
let's
Simon,
hope.
there is question. Thank you for your greetings. There is question. Thank you. Please, if patient not intubated, we will do ambu bagging or just put face mask.
No, we'll not do the ambu bagging. We must try to avoid ambu bagging because this is aerosol generating procedure. So just put the face mask and don't forget to off the oxygen supply while you are going to shock the patient. Even that time you will not remove the face mask. Just off the oxygen supply from behind, shock the patient, and you can resume back your oxygen.
Thank you, doctor. Any other questions, please? Okay. I think there is no question appearing, so 1 minute. Yes, okay. No question appearing on the chat. So thank you, Dr. Simon.
Okay, thank you, Dr. Bultagi. Thank you.
And next session will be led by Dr. Walid. He's another excellent speaker, and he will present an interesting lecture with videos and with very interesting topic, airway management, and especially airway management in COVID. And I think you will find many important and updated information from his presentation. You welcome Dr. Walid, and share, can you share your slides, please? Dr. Walid, can you join us, please? Dr. Walid? Dr. Walid?
He's joining Dr. Abdul now.
Assalamu alaikum.
Alaikum salam. Welcome, Dr. Walid.
Thank you very much. I'm really sorry. I had my schedule mixed up. I forgot. So I'm really sorry if I caused you some delay.
You're welcome.
You want me to start right away?
Yes, I introduced you already, Dr. Walid, and please.
Thank you very much.
Can you share?
Thank you. Okay, I will share my screen and get started. So good evening, everyone. I'm sorry again for the delay. My talk is about airway management. My name is Walid El-Itrebi. I'm an ICU specialist with a background of anesthesia. At the beginning, I would like to disclose that I have no conflict of interest because we'll be playing some videos and I have no copyright to any of those videos. I want to start by saying that when we say airway management, I mean by that only one thing, which is to maintain the pathway between, say, the nostril to the beginning of the respiratory system or the larynx open, or it could be from the mouth to the beginning of the respiratory system. That's all I'm concerned with, keeping this pathway patent. I am not really concerned with whatever we are giving from outside. So very quickly, we'll just touch on the simple techniques. This is the technique that we all practiced in BLS, which is called jaw thrust. In jaw thrust, you only place your fingers, index and middle, on the bone of the lower mandible, on the bony angle of the lower mandible, and you try to displace the lower mandible upwards. This pushes the tongue away from the posterior pharyngeal wall. Very simple technique. A similar technique is called head tilt jaw thrust, where using one hand you tilt the head or extend the neck, and the other hand, again, I emphasize on the bone of the lower mandible. You displace the tongue upwards. You displace the jaw upwards, and when you do this movement, the tongue will be moved away from the posterior pharyngeal wall, which it was obstructing before. I just want to emphasize that both techniques are similar to each other in success. However, in the head tilt, there is an extension of the neck. So as a rule, it should be avoided whenever you have suspicion of cervical spine injury. And this is your suspicion until proven otherwise in case of trauma. So any case of trauma, until proven otherwise, you have a query, cervical spine injury, do not use head tilt jaw thrust. Now let's move forward to something a little bit more complex, which is using the oropharyngeal airway. As you can see, the oropharyngeal airways are different sizes, and each one of them is color-coded. Now, the color codes are used to give you different sizes that fits different patients. In general, whenever we are using a device for airway management, we have to choose the proper size that fits the patient. However, we are not going to memorize tables such as this one that tells you which color suits which patient, because there's a very simple, rough method that helps you decide whether the oropharyngeal airway fits your patient or not. You put the plate or the upper part in parallel or in line with the incisors or with the lips of the patient, and the tip should end at the bony angle of the lower jaw. If it's less than that, then this is too small, and it's not going to displace the tongue away from the posterior pharyngeal wall. That is to say, it's not going to open the airway for you. Or if it's too long, it's going to go beyond the pharynx, and it's going to approach the larynx. This will cause irritation, will cause coughing, will cause gag reflexes. So this is a very simple, rough method to help you determine the proper size for your patient. Regarding the insertion, keep in mind that when you are inserting an oropharyngeal airway, the direction of insertion is opposite of the anatomy of the airway. That is to say, the oropharyngeal airway is C-shaped and it's taking the normal curvature of the airway. However, when we inserted the other way around in the opposite direction until you hit the hard palate, as you can see here in this drawing. Once you hit the hard palate, you start rotating while pushing forward. And the reason for that is that you want to avoid the tongue. You want to get away or be far from the tongue so that it doesn't interfere with your insertion. We're going to skip, for the sake of time, insertion of the oropharyngeal airway, but before leaving it, I just want to emphasize on an absolute contraindication of the oropharyngeal airway, which is intact gag reflex. So if your patient has an intact gag reflex, don't think of the oropharyngeal airway. Moving next to something slightly different, this is the nasopharyngeal airway. So it goes through the nose of the patient, and the tip also ends in the pharynx. That's why it's called nasopharyngeal. In contrast to the oropharyngeal airway, the nasopharyngeal is made of very soft rubber. You can bend it, you can deform it as you wish. It's much, much softer than the oropharyngeal airway. And the reason for this difference is that the oropharyngeal airway is inserted in the mouth. So if the patient bites, closes his mouth, or clenches his teeth, has seizures, for example, being hard plastic, he will not be able to occlude or obstruct the oropharyngeal airway. But since the nasopharyngeal is going through the nose, it's away from the mouth. So even if the patient closes his mouth, he will not be able to occlude it. That's why they were able to make it of soft rubber. Now, again, we don't have to memorize sizes. There is a rough technique also here that helps you decide whether it fits your patient or not. But this time, starting from the nose, this is a nasopharyngeal, and the tip should end at the ear lobule of the patient. This is what the nasopharyngeal airway looks in place. And as you can see, it's going through the nose above the hard and soft palate. So even if this patient closes his mouth, he will not obstruct it or close it. We mentioned that an intact gag reflex is an absolute contraindication for the oropharyngeal. Now, this is completely overcome by the nasopharyngeal. The nasopharyngeal airway is very well tolerated by almost completely conscious patients. And I will show you a very interesting picture in a while. But it also has its own absolute contraindication, which is in fact the absolute contraindication of anything going through the nose. Nasopharyngeal airway, nasal intubation, nasogastric tube, anything is contraindicated to go through the nose if you have fracture base of the skull. So fracture base of the skull is the absolute contraindication of the nasopharyngeal airway. Again, I will skip the insertion technique because it's very, very simple. Just put it in the nostril and push forward with enough power or force, and it will seat in its place. This is a picture taken from a demonstration video in which this is a respiratory therapist, by the way. And as you can see, he's inserting a nasopharyngeal airway for himself. So this tells you how well tolerated it is by completely conscious patients. It overcomes the problem of an intact gag reflex. But don't forget, it is contraindicated if there is fracture base of the skull. Now, suppose we are still not successful in maintaining the airway, we are going to move to another airway. So, although it looks a little bit complex or complicated, it is still an airway. This is called the laryngeal mask airway. Laryngeal mask airway is simply made of a shaft. This end is the patient's end, which we call the elliptical shaped balloon. And the elliptical shaped balloon gets inflated with air through this side tube, in which you inject air by just a normal syringe. And when it is inflated, it creates a seal. However, I just want you to remember the word seal. We'll come back to it in a minute. The other end, which is your end, has what we call universal connector. This means it can connect to an ambu bag, to an anesthesia machine, to a ventilator in the ICU, anywhere in the whole world. Universal connector. Now, this is, remember, it's still an airway. So it doesn't go into the larynx. It just remains outside the larynx. That's why it's called laryngeal mask. It masks the larynx or covers the larynx, but it doesn't go inside the larynx. Again, there are different sizes, and different sizes fit different patients. And again, I'm advising you not to memorize these tables for a very simple reason. Each laryngeal mask airway has its part of this table written on it. So if an LMA is size 3, you will find this information written on the LMA itself. Regarding the insertion of the laryngeal mask airway, this is a little bit of a technique that requires or needs training and practice. There are several techniques. Personally, I prefer the classical teaching method insertion technique, and I will show you a very short clip on that. But to explain it before we see the clip, you hold the LMA as if you are holding a pen, and this index finger is going to play an important role. You are going to use it to push backwards against the hard palate. And again, the point here is to avoid friction with the tongue. And you go in as far as you can, blindly, and these three fingers outside the mouth will stop you when you reach the maximum distance you can go in with your index. Once this happens, leave it, it's in place, right? It is simple, but it requires some practice. Before I show you the clip, this is what the laryngeal mask airway looks when it is in place. As you can see, it is just masking the larynx, but it never got inside. Now, remember when I told you, when we inflate this balloon-shaped, elliptical-shaped balloon through the side port, it creates a seal. However, this seal is not 100% perfect. So although it is a seal, there is still some leak. And I want you to imagine, if air leaks, it will go only to one place, which is the esophagus. Once air goes to the esophagus, the stomach starts to inflate, and eventually there will be vomiting. And this is the absolute contraindication of the LMA. The LMA's absolute contraindication is full stomach. So remember, each one of the airways has its own absolute contraindication. Oropharyngeal, intact gag reflex. Nasopharyngeal, fracture base of the skull. Laryngeal mask airway, full stomach. And by the way, anesthesiologists define full stomach as the patient has taken a meal or food within the last 6 hours and has taken a non-clear liquid within the last 2 hours. Non-clear liquid means something like milk, like mango juice. But tea is a clear liquid, so this definition doesn't apply to it. So here, full stomach is a contraindication of using the LMA. I will show you now what I meant when I told you the LMA has all the information that you need to know about it written on it. So you did see that all the information you need to know about the size, which patient, about the amount of air you inject to create the seal, it's all written on the laryngeal mask itself. Now I will show you the technique of insertion. Usually, of course, in our practical workshop, we do that by our hands, but we have to be content just with watching the video. But before I start, I want to tell you that in my days, when I was being trained as a resident, I was always told, keep some amount of air inside the elliptical shaped balloon just to prevent its kinking or folding while you are inserting. This old teaching has changed now, and the recommendation now is to completely deflate the elliptical shaped balloon. I will show you now the classical method that we just saw on the diagrams. So as you can see, he's completely deflating the elliptical shaped balloon by withdrawing the air using the syringe. Now he's going to lubricate. And remember that you lubricate the back side of the LMA, the part that is not face the larynx. And because this is the part that's going to slide against the hard palate when you push with your index. Notice the other three fingers stopped him from going any further. Now it's in place. All you have to do now is to fully inflate the elliptical shaped balloon, and you make sure that it is facing the larynx when the black line on the back of the LMA is aligned with the incisors or the nasal septum outside. This is the classical method that I personally use, and this is the method I was trained for. But there are other methods. Out of interest, I just want to show you another technique of insertion. So although the principle is the same, he used his index finger to push the lubricated back of the LMA against the hard palate, pushing inwards blindly. The other three fingers stopped him from going any further. The same principle, but the technique was slightly different. So now, by now, we have gone through using our hands, oropharyngeal, nasopharyngeal, and laryngeal mask. Remember, none of those techniques got into the larynx, so none of them is 100% secure. And that is why the golden standard of airway management is the endotracheal tube. By the way, this is what we call intubating laryngeal mask. And I put the picture here because we will mention it in a while when we discuss the COVID pathway. So this is a laryngeal mask airway. It is the same, only that once you insert it and it's in place, it allows you to insert an endotracheal tube through it, and we use it in difficult intubation. We'll come back to that. So now the golden standard of airway management, the endotracheal tube. Structure-wise, the endotracheal tube is a shaft. Again, this is the patient's end, and this is the part that goes inside the larynx and ends in the trachea. This is a balloon that we call the cuff. You inflate it with air through this side port, again using a syringe. So once you inflate this balloon, it creates a seal inside the trachea. Now this seal is 100%, so it doesn't allow anything beside the tube to come in, or doesn't allow the air or the gas you are giving in the tube to escape out of the larynx. The other side is your side, the operator side, again with the universal connector. Now, endotracheal tubes come in different sizes and shapes. I hope this image is clear. This tube is slightly different because it has a coiled metal wire within the shaft. This is what we call the armored tube, and we use it when we have to operate a patient, for example, in the prone position. Pediatric tubes do not have a cuff. As you can see, these are the cuffs in the adult tubes. The pediatric tubes don't have cuffs. because the cuff, when it is inflated, especially with high pressure, it causes necrosis and injury on the inside of the trachea in children. Now, choosing the proper size of the tube. For adults, it's not a real big issue. Usually, we use for a male a tube of 7.5 up to 8, sometimes even less than that. I would use 7 if I were in the OR. For a female, something a little bit smaller. I can even start from 6.5 to 7.5. So what are these numbers? If you look at an endotracheal tube, you will find something written here. For example, this tube has written on it ID8. ID means internal diameter, and 8 is 8 millimeters. So this is the size of the tube. So whenever you hear in the ICU or in the OR or ER, someone saying, give me a tube 6, give me a tube 7, this is what they mean, the internal diameter of the tube in millimeters. So for adults, as I told you, it's not a big deal. Usually we go from 7 up to 8 in a male, from 6 up to 7.5 in a female. The issue is with children, you have to choose carefully because, as we said, you might cause injury to the trachea if the tube is too large. The formal or the most famous formula is this one, 1/3 of the age plus 3. So if you have a 3-year-old child, 1/3 of that is 1 plus 3, that gives you a size of 4. Another less famous formula is 1/4 of the age plus 4. So if the child is 4 years old, 1/4 of that is 1 plus 4 gives you 5. And as a general rule, when we intubate, if you have decided, for example, that I want to use a tube of 6, prepare with you one size above and one size below. So if you say tube of 6, prepare 5.5 and 6.5, because you don't know what you are going to see inside while you when you start intubating. But there's something more important than just sizes and numbers. It is your purpose of the tube. Why are you intubating the patient? For example, in the OR, an anesthesiologist intubating a patient knows that he is intubating for the duration of the surgery, which will be 1 or 2 hours. And then at the end of the surgery, he's going to extubate his patient. So he's looking for the smallest suitable tube so that it doesn't cause irritation of the trachea. While we in the ICU, when we intubate patients, we know that the tube is going to remain there for a while, for a few days, perhaps a week. And in that case, we want a tube that doesn't easily get obstructed with dried secretions. We want a tube that doesn't create a high peak airway pressure alarm on the ventilator. And we want a tube that facilitates suctioning through the tube itself. And that's why in the ICU, we look for the largest possible suitable tube for the patient. So you have to choose carefully based on your need of the tube. Okay. This is what the tube looks when it is in place. It has gone through the mouth, and as you can see, it has gone through the larynx. And once you inflate this cuff, you have created the seal. Now, nothing can come from the side of the tube. So if the patient, for example, vomits or there is secretions or bleeding, it will not get into the lung. And at the same time, when you give oxygen, for example, it comes out of this end and it cannot escape out of the larynx. And it is very common when you are, for example, walking in the ICU, just passing by a patient who has a problem with this cuff and it's not fully inflated and creating the seal, you will hear a very distinctive sound. The sound of air escaping from the trachea and going out of the mouth through the secretions and saliva. So it gives you the sound of air passing through water. It sounds something like this. And you immediately will recognize that there is a leak with this patient. And the first thing you have to look for when you suspect leak is this cough. Before I leave this graph, I just want to remind you of something very important. If the patient is intubated and the cuff is inflated, secretions accumulate above the cuff. So when you are extubating your patient, remember, always remember to do thorough suction of these secretions before you deflate the cuff. Because if you don't do that suction and you just deflate the cuff, all the secretions that have accumulated here are going to go inside the lung. And it will cause aspiration to the patient. And that's why nowadays, the more modern tube have a suction port placed right here. This is called supraglottic suction tubes. Okay, so what are we intubating? Where are we inserting our tube? We are inserting our tube in this area, which is the area between the two vocal cord, what we call the glottic aperture or the glottis. And beyond that, you can see there is the trachea. You can see the tracheal cartilaginous rings here. And this is what you hear all the time, anesthesiologists or intensivists saying or calling it as the view. When you hear someone say, I don't have a view, or I have a very good view, this is what they are referring to. Visualization of the vocal cords, the glottis, and the trachea beyond the vocal cords. Now, there's only one problem. There is no direct line or straight line between your eyes and the vocal cords. So if you look directly in a patient's mouth, you cannot see the vocal cords. And that's why we need another instrument that helps us visualize the larynx and expose the view. At the very beginning, or initially, this was the most common or maybe the only device available, which we call a laryngoscope. And the laryngoscope comes in different shapes and different modifications, but basically they are two main types. One with a curved blade. As you can see, this blade is curved, and this is called Macintosh. And one with a straight blade, and this is called Miller. Regardless of the different modifications, these are the two main important types. There is a very important practical tip when you are using a laryngoscope that you have to keep in mind. If you are using a curved blade, that is to say a Macintosh laryngoscope, or even a glidoscope, because the glidoscope also has a curved blade, you have to place the tip of the blade in a very specific area. And that area is the anatomical base of the tongue. This is the tongue, and the epiglottis. This is the epiglottis here. This is the common base of both. And anatomically, this is called vallicula. And that's why some people say, think valliculoscopy. You are trying to visualize the vallicula, not the vocal cords. Why is that? Why is it important to put it in the vallicula? Because there's a very small ligament. You can see here in this picture. It's called hyoepiglottic ligament. And this ligament runs between the epiglottis and the hyoid bone. Once you press that ligament with the tip of the blade, it causes the epiglottis to rise up and reveal the vocal cords beneath it. So it's like moving a marionette. When you want to move an arm of a marionette, you don't move the arm itself. You pull the string attached to the arm. This is the same principle. When you want to move the epiglottis and raise it upwards, you just press on the hyoepiglottic ligament. So if the blade is placed in the vallicula with the tongue above the blade, this means that you do not see the tongue. But with the epiglottis below the blade, this means you can see the epiglottis. So when you are intubating, make sure that you do see the epiglottis, because if you see the epiglottis, this means you are in the correct position. If you don't, this means you are performing a wrong technique. Then the laryngoscope was modified and advanced. Came the glidoscope. Instead of the light bulb, they put a camera, and the camera displays on a monitor. This is the glidoscope. Then came the video-assisted laryngoscope, which also uses a camera, but the monitor is smaller and on top of the handle. These are advancements of the classical laryngoscope. Now, I'm going to show you an animation clip of intubation using the glidoscope. As we said before, the glidoscope is almost similar to a Macintosh curved blade laryngoscope. The only difference is that when you are using a Macintosh, you try to sweep away the tongue by going from right to left. With the glidoscope, you don't have to do that. You go right in the midline. This is just an animation, but it details the steps and it's very useful to watch. So we have seen this animation. I will show you now the actual landmarks of the airway that you do see either directly with your eyes or on the glidoscope screen as you are intubated. So I hope it was clear, the steps using the glidoscope and the anatomical landmarks that you see during intubation, and the importance of a correct placement of the blade in the vallicula between the tongue and the epiglottis to get the best view. Now I'm going to move to something that relates to the situation we are in. This is the emergency rapid sequence intubation approach devised for intubating a COVID patient. Now, what is so special about a COVID patient with regards to intubation? The patient with COVID, his airway is not in any way different than a normal patient. But the issue here is two important points. The first point is that you want to minimize the time that you take for intubation. You want to decrease or minimize the time that you spend with the patient. This is number one, and that's why it is a rapid sequence. And the second thing is that you want to minimize as much as you can the aerosol generation, the generation of droplets, because that's what contains the virus. So this is what's so special about intubating a COVID patient. You want to make it very quick, very fast, and without producing aerosols. So let's break this algorithm into parts or pieces. The first part, in my opinion, is the most important part, which is the part about preparation. Before you go and intubate a patient in a COVID situation, prepare everything ahead. Again, as I told you, we want to decrease the time. You don't want to look for something while you are manipulating the airway, you don't find it, you ask for it, someone goes to bring it for you. This is a wasting of time. So preparation is very essential. Preparation of what? Preparation of instruments. You prepare your glidoscope. Here in COVID patients, it's recommended to use the glidoscope, not the direct laryngoscope, because you want to stay away from the patient as much as you can. Prepare your tubes, your stylets, a suction, every instrument that you think you will need. This is number one. Number two is the drugs or the medications. You prepare your induction agents. You prepare your muscle relaxants. You prepare your analgesia or sedatives. Everything must be prepared ahead so that we don't waste time during the intubation itself. Another very important item in preparation is make sure that you are in full protective, personal protective equipment, PPE. Make sure that you and your team working with you are fully protected. I remember an article that was published recently saying there is no emergency in a pandemic. And what it meant is that don't feel obliged that, hey, this is an emergency, I need to intubate this patient immediately, and you go in the room unprotected, because this way you are going to harm yourself and you might spread the infection to your colleagues. And instead of, what's the worst scenario? Losing the patient? Instead of losing one person, we are going to lose 4 or 5 or even more. So there is no emergency in a pandemic. Make sure that you are fully protected and your team. So make sure you have all the protective gear on. Check yourself and your team and adjust for each other your protective equipment. Then proceed to intubation. The other point with preparation is that we use glidoscope and we use video-assisted laryngoscopy. So once, I will show you now a very short clip on this topic or this point of preparation. In KSMC, we have prepared the team that is responsible for intubation, and it is 3 members. The physician, who is supposed to be the most experienced in airway management, plays the role of the leader. And then there are 2 other members, a nurse and an RT. The nurse will be handling the medication, and the RT will be handling, assisting in intubation and handling the ventilator. So this is what the preparation looks like. So this is the team formation, and this is the preparation and the checklist. Now, this team formation of 3 members, the one we are using in KSMC, doesn't always have to be the case. Some other institute in your hospital, it might be slightly different. This is another video clip on the preparation, but my intention for it is slightly different. That's why I'm going to skip part of it. But before starting it, for example, in this clip, there are 4 members. The 4th member is outside the room, and they call him the clean person. The clean person is not in PPE, and he is there to assist when they need to, for example, if they need to grab some instrument or to call somebody for help, he is ready to go on there, to go and do that. So he's the 4th member. It's not always 3 members, so it depends on the institute. But more importantly, this clip will focus on my second most important point, which is minimizing the aerosol generated during intubation. So for example, if you want to mask ventilate the patient before intubation, the recommendation is to do it passively, not using the bag, because again, this is aerosol generating. But suppose the patient is desaturating and you must bag the patient, it is very important that you create a very strong seal with the mask on the patient's face using both of your hands. Another very important point to minimize the droplets is if you want to switch the patient, for example, from the ventilator to an ambu bag, suppose you are transporting him, it is very essential that you clamp the tube in inspiration before you disconnect it. Because if you disconnect before clamping, aerosols might come out containing the virus. So I will play this part of the tube. This is the part that interests me. As you can see here, these are the 3 usual members, but this is the 4th clean person. I will jump to the part that I'm interested in. She's here describing the same preparation as we said before, but I'm going to move forward to the part I'm interested in. As you can see, she's trying to fit the mask, and they are not ambu. So we did see here how she used both her hands to create the tight seal when she needed to bag mask the bag ventilate the patient, how they clamped the tube in inspiration before disconnection, how they inflated the cuff of the tube before connecting to the ventilator. Now, let's go back to our algorithm. So we have done all this preparation, and the most experienced of the team approached the airway to try and intubate. So this is called Plan A. What if he fails his first attempt of intubation? I mean, if the first attempt of intubation is successful, then that's it, and the whole procedure is done. But what if he fails? If he could not insert the tube? Now you have to ask yourself a very important question. Am I able still to oxygenate the patient, like only by passive CPAP without ambu bagging, or even by face mask ventilation, or by a supraglottic device, that's the laryngeal mask airway? Can I still maintain some ventilation to the patient, although there is no tube? If your answer to this question is yes, then you can relax a bit because you are not in an emergency situation. This is the situation we call cannot intubate, can ventilate, because you're not going to lose the patient. You are still able to ventilate him. So as you can see, you have time for other options. Now, what are these options? The first option is another trial with for intubation, but you have to do something differently because you are the same, the patient is the same. So try something else. Like what? Like use a larger blade. If you were using a laryngoscope, change it to a glidoscope. Put a stylet inside the tube if you haven't already done so. Have an assistant push down the larynx from outside to make it come down so you can visualize it better. You can have a second attempt after making these modifications. But if you believe that you have already done all these things and they are not going to be useful, then don't waste time. Remember, we said the most important thing is minimizing the time. So move to Plan C. Plan C is what we call the exit options. The exit options, exit out of the situation. Can be what? Can be placing a supraglottic device, the laryngeal mask airway. You can consider intubating through an intubating laryngeal mask, the one I showed you the picture at the end of the section with the LMA. So you can use a supraglottic and an LMA, and through which you might intubate. Or if you think that this is not going to help, again, you can go to the fastest way of getting out of the situation, which is obtaining a surgical airway, what we call cricothyrotomy. And here in this algorithm, it is recommended to be bougie assisted. And I will show you what is a bougie assisted cricothyrotomy in a while. But let's go back here where we failed our first attempt. And when we asked ourselves, can we maintain still ventilation of the patient, whether passively or by bagging or by a supraglottic device? And the answer was no. We are not able to do that. Then you are in a real emergency situation. This is life-threatening because this is the situation we call cannot intubate, cannot ventilate. Here you don't have time. You need to make very fast decisions and carry out your decision very quickly and efficiently, because otherwise you lose the patient. On this pathway of an emergency situation, it is essential that you call for help. There is no pride in not calling for help, saying, I'm very experienced, I can do it. Don't do that. if you feel that you are in an emergency situation, always immediately call for help. And then again, if you think that another attempt using the LMA or face mask ventilation using 2 persons, notice this, because you are going to use both your hands to hold the mask and create the tight seal, so the second person is going to ambu or ventilate using the bag. If you think this might be beneficial, try it. However, if you think that this is going to waste time, not going to be successful, and you are in this emergency pathway, then go directly to the exit option, which is the surgical airway or the bougie-assisted cricothyrotomy. I will show you the bougie-assisted cricothyrotomy, and notice it's being done by military personnel, because this is the method of obtaining an airway during wartime in the battlefield. This tells you that it is used in dire straits of emergency, number 1, and number 2, it tells you that it is very fast and very quick. Here it is. So this was the bougie-assisted cricothyrotomy. Although there is another way, which is also cricothyrotomy to obtain a surgical pathway, but it's a little bit more neat, more clean. This is using, instead of the bougie, you use a guide wire, similar to the guide wire that we use to insert a central line. But it seems that the bougie-assisted method is faster and quicker. And remember, the point here is to decrease the time. I'm going to skip that for the time being. Now, before I end, I want to remind you that our pathway is called rapid sequence. So it's all about time and decreasing the time used. I had promised Dr. Ahmad Madi to put 1 or 2 slides about rapid sequence intubation, but I didn't get the time to do that. So I apologize for that. However, just let me remind you about RSI, rapid sequence intubation. If you go through any rapid sequence intubation steps, you will discover that it's again all about preparation ahead. Everything should be prepared before you start because there's no time to lose once you start intubating. So it's about preparation of the instrument, preparation of the medications, and usually the medications recommended here is to use muscle relaxants. In the ICU, we usually don't use muscle relaxants. However, in RSI, it is recommended because this, again, will minimize the aerosol generated because the patient will not cough. If you haven't given muscle relaxant, the patient might cough. So with a muscle relaxant, you decrease the aerosols generated. And it is recommended to use succinylcholine or succinylcholine, of course, unless otherwise contraindicated. There are some contraindications for succinylcholine. In such case, you have to use a non-depolarizing muscle relaxant. You might use cisatracrium, for example, again, because it is the one that induces muscle relaxation in the shortest time after succinylcholine. You also prepare the position of the patient in rapid sequence intubation. You also prepare yourself for what is coming ahead by thoroughly examining the patient. This is very, very important, whether it's rapid sequence or even routine intubation. You have to examine your patient thoroughly, trying to find out or to discover what might cause difficulty while you are intubating. Examine his facial features, examine if there is loose teeth, if there is a swollen or enlarged tongue, examine the mobility of the neck, whether the patient's neck can be extended or not. Examine the mandibles, is it receding or protruding? Examine for loose teeth. So thoroughly examine the patient. So again, I apologize, I didn't put the promised 2 or 3 slides on rapid intubation, but shortly or briefly, rapid sequence intubation is all about good preparation and examination of the patient. With that, I conclude. I wish you all safe airway management, and thank you very much. I'm done, and I'm ready to take questions.
Thank you, Dr. Walid. Thank you very much. Very interesting and detailed.
Thank you very much, Doctor.
If someone has questions, please. Seems there is no questions, so thank you again, Dr. Walid.
Thank you very much.
Yeah. So,
I wish you all a pleasant evening, and thanks for having me once again.
Thanks again, Doctor. So
Thank you.
to all audience, please now you can start your exam. It's shared in the group, so you can enter the link. Please write properly your name and email address, as it will be represented in your certificate. So good luck and thank you all.